over 1 trillion rupiah. PT Meiji Indonesia spread its wings of expansion, where one expansion leads to the next. Horizontally, we are racing ahead to fulfill both domestic and overseas market with certified quality API even more competitively. Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into cosmetics, food supplements, OTC, and household medical supplies. We have also accomplished our strategic expansions of our plant and its facilities. Our modern warehouse to safeguard the quality of our products. Life journey serve the country and the world. In the spirit of the company's vision, we are dedicated to carry three-dimensional purposes to bring PT Meiji Indonesia as a clean, green, and trusted company. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, professor and doctors. Welcome to our webinar. This is our third dry eye webinar, which will talking about dry eye. We are working together, INOES, Santen Indonesia, and PT Meiji. So hopefully you can have a good webinar, get increase in the knowledge for Indonesian doctors. This webinar will be led by our moderator, Dr. Fatma. She was graduate from Faculty of Medicine, Cairo University in 1970 and underwent ophthalmology training in University of Indonesia from 1980 to 1984. And then graduated from ophthalmology specialist in 1984. Then since then, she's teaching teaching staff for student and resident and University of Indonesia Faculty of Medicine, as well the international class. She's a senior consultant in infection immunology services at the Department of Ophthalmology. She also a national board examiner at the FKUI, and also frequent lecturer at the national and international conference as invited speakers and members of several nations, as well as international society. She was the past president of the INOS, Indonesian Ocular Infection and Immunology Society, from 2000 till 2017. She's now also the president of Jakarta Branch Indonesia Eye Bank from 2014. She's now practicing as a senior consultant in Eye Hospital, Pondok Indah Hospital, and Majestic Eye Clinic, Jakarta. Please welcome Dr. Fatma Azhari.
Halo, terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Siang ini atas nama Indonesian Ocular Infection and Immunology Society, pertama-tama saya ingin mengucapkan terima kasih kepada PT Meiji Indonesia yang sudah mengadakan acara ini, dan juga terima kasih kepada semua peserta yang telah menyempatkan diri untuk hadir untuk mendengarkan ceramah dari tamu kita hari ini. Tamu kita hari ini adalah Profesor Puangsricharern, akan membahas mengenai practice essentials, hal penting praktis karena IC merupakan yang sangat umum dan yang paling sering ditemukan di praktik kita sehari-hari. Kalau dahulu yang lalu mungkin sejak 2 bulan pertama kita mengobati dry eye berdasarkan simptom, berdasarkan pasien, tapi dengan kemajuan ilmu oftalmologi, sekarang kita lebih berdasarkan targeted therapy. Jadi lebih ke arah tier film, bagian berapa tier film yang kurang baik, yang kurang ini, itu yang akan ditargetkan. Lebih ke environment daripada tapi ada memang satu faktor, sangat banyak faktor yang berperan itu. Ada merupakan satu inflamasi yang harus dia. Kemudian kan kalau kita tidak juga berat, ini suatu penyakit yang kronik tahun-tahun, yang orang kadang-kadang juga pasien akan memakai obat yang harus sering, mungkin setiap jam dalam satu hari, itu akan menjadi salah, sehingga kita bisa mengetahui atau investigasi menentukan faktor apa yang berperan untuk pengobatan, dan kita bisa mengobati dry eye, tidak sedikit treatment tanda secara saya akan mengundang tamu kita. Good afternoon, Prof. Vilavun. Hello, welcome, Prof. Vilavun. Nice to meet you again.
Nice to meet you too.
Next time when COVID-19 we can see each other again. I mean, in reality. Her topic will be essential and targeted in managing dry eye. I think so I waste our time. I would like to do a presentation. I've got around 30 minutes to present. Let me read Vilavun. This is the of Professor Vilavun Puangsricharern from the Department of Chulalongkorn, Thailand, and he's graduated in 1985 and a graduate of ophthalmology in 1989. I think postdoctoral training, certificate of residency, research fellow in external eye disease, certification and license from medical license and Thai ophthalmology royal societies, as a lot of experience and she is president of the Refractive Society of Thailand, Royal College of Ophthalmology of Thailand. Question, Prof. Vilavun.
Good afternoon, dear colleagues from Indonesia. I'm very happy and very honored to be a guest lecturer for you today. And even though we are in a long distance, but I think and the discussion that we may going to have in the few minutes after that will be just like we are close together. And I just hope all of you in very good shape. So my topics today will be clinical focus on the practical point in dry eyes, especially in terms of the therapy and management. And this is my financial disclosure. Why do we have to understand dry eyes? Well, there are several good reasons for that. The first one is that because if you look at the map here, there are increasing, especially the high prevalence especially in the Asian country. For example, in Indonesia, you have a study which showed that 27.5% of the prevalence dry eyes in Indonesia. Whereas in Thailand, if you look at the population base, the number will be 14. If you look in the hospital-based patient, this number increased to 34. The second reason is because we are Asian. Asian race is one of the risk factors in increasing dry eyes. And this table is from the DIUS 1 that we already learned about. The third reason is because of the burden of the disease. If you look at the utility score here, dry eye, which is the moderate dry eyes, the utility score is pretty much the same as, for example, the disabled hip fractures. So for patients with moderate to severe dry eyes, that really quite cause a lot of burden in terms of, the social function and everything, the quality of life. This is the diagram of showing how dry eyes knowledge have been evolved through years. Especially in the 2017, there are two prominent papers that is coming out. One is the DIUS 2, which is the second report from DIUS 1. And the second one is the Asia Dry Eye Society. I would like to focus my talk a little bit on what is the difference between this, DIUS from the T-Force group and Asia Dry Eye Society, which is from our Asian country. First, the DIUS 2 definition in 2017. This is the diagram, and if you look at the definition in the right, summarized for that is that they are looking at 4 important factors that can cause dry eyes. The first one is the tear hyperosmolarity. followed by tear film stability, ocular surface inflammation, and the neurosensory abnormalities. These four factors play important and a close relationship together. And this causes a vicious cycle, as you see here in the left-hand side, causing dry eyes and developing all the symptoms of dry eyes in the patient. Comparing to the Asia Dry Eye Society, which this is the first definition, which coming out in 2014. If you look here at the diagram on the left-hand side, the important thing is that the tear film instability, the unstable tear film is the hallmark and the prominent features of dry eyes. And from unstable tear film, this can leading to the symptoms of dry eyes, the visual impairment, and of course the ocular surface damage, whether that would be an evidence of the signs or not. So for Asia Dry Eye Society, the key factors is the tear film instability. What about the classification? What is the difference between the DEWS 2 and the Asia Dry Eye Society? And this diagram is from DEWS 2. Seeing here, this is a very good diagram to follow, but a little bit difficult, complicated. But I can summarize it here. Look at the pink bracket here. If the patient comes to you with symptoms of dry eyes, and you examine and you found the signs, all the signs of dry eyes, that make you make a diagnosis of dry eyes and ocular surface disease. But what happens if the patient has only the symptoms, dryness, burning sensation, but when you look at the patient, there is no signs of dry eyes. So that can be from the neuropathic pain, which is the new element that they just added into the new definition, neuropathic pain, or the patient may have the preclinical dry eyes. But if you examine the patient and you found a lot of stainings, especially in the central cornea, conjunctival, but the patient very asymptomatic, they don't complain anything about dryness. So this leads to condition that the patient may have the neurotrophic condition. For example, the nerve, the ophthalmic branch may be impairment, or other causes, herpes infection that can cause the neurotrophic condition. And the patient, this group of patients are at higher risk for developing dry eyes. And the bottom of the diagram, you can see that for DEWS, they divided the patient of dry eyes into three groups. The one on the left-hand side is the aqueous deficiencies. The yellow one belongs to the patient with evaporative dry eyes. And of course, the mixed type, which is the majority of the patients. What about the Asia Dry Eye Society? And this paper just coming out in 2019, which is very good to illustrate it here. They divided and classified dry eyes into, first group is the aqueous tear deficiencies, which is just the same as in DEWS. The evaporative dry eyes, and adding the third group, which is decreased wettability dry eyes, simply called the insufficient mucin protection on the ocular surface. And the first group is mixed. Many times we will see the patients in mixing between, for example, aqueous tear, the first group, and decreased wettability, or any kind of combination. But how to diagnose this classification? They point out in this diagram that in order to diagnose, you have to classify which type of the breakup pattern. For example, aqueous tear, you have the area line break, the random break, or the spot break. That even make the important point that tear film breakup pattern is very important in order for classification. And that is what we already know as the tear film oriented diagnosis, which is the TFOD. What about the diagnosis? Diagnosis of the dry eyes in terms of the DEWS group, they use history. Remember history, and they ask the questions and the risk factors. And they use the diagnostic test, that means the signs that the patient may have, including the symptoms, as scoring here, plus one of the signs, which may be tear breakup time less than 10 seconds, the osmolarity, tear osmolarity more than 308, and the cornea and conjunctival staining, which you need both the history and you need one, at least symptoms and one of the signs. But for Asia Dry Eye Society, the new diagnostic criteria, which is just coming out in 2017, is that if you have dry eye symptoms plus decrease or unstability of film, no matter what, you don't really need the staining. So that is called dry eye. You can make a diagnosis of dry eye. So to make it short, symptoms plus tear breakup time, which is less than 5 seconds, is considered as the dry eye diagnosis. Then in the second part, I would like to share my approach to dry eyes patient. I'm not going to touch about all the the basic or the knowledge behind that, but I would like to share how I use, what is my practical use in the clinic. First, I will, for the diagnosis to be made, I will ask the patient. Yes, of course, when the patient came to your clinic, because they are complaining about dryness or the burning, the gritty sensation, foreign body sensation, light sensitivity, the fluctuation in the vision. And this is the main symptom that bring them to you. And then after that, then you start to ask some question about the severity, whether this is severe, the frequency, whether the symptom is disturbing their normal life or not. How long have these dry eyes happen? Most of them, if they have a chronic dry eyes, they may have like months, develop for years. What about the diurnal variation? Ask them whether they have it more severe in the morning or more severe in the evening. So that also make a difference, because most of the aqueous tear deficiencies, the patient will continue or increasing symptoms, especially in the latter part of the day. Ask about what is their underlying disease, especially the autoimmune disease, what medication they are using, both the systemic, because we already know anticholinergic, anti-allergy, or the antidepressant, antihypertensive, that can cause dry eyes. And another part is the topical drug, because some of the patients may not have only dry eyes. They may have other disease. For example, glaucoma is one of the diseases that, anti-glaucoma that can cause dry eyes. What do they, whether they have any previous ocular surgery, for example, the cataract surgery, they have the blepharoplasty, all these dry eye symptoms happen after the surgery or not. And then whether they have any treatment from the ophthalmologist before you. I happen to find that sometimes the patient came to you with a lot of symptoms and you see a lot of staining. But when you examine through all the history, I noticed that they have many kind of treatments, even, more than 5 or 6 medications at the same time. And that makes you wonder whether this dry eye is really what they are having, or even they have what we call the medicamentosa or not. So the previous treatment is also very important. And then I start to look at the eyes. This is very important part, and to examine the patient, you need a very good microscope. I personally, and of course at my setting, my clinic, my university, we are using this kind of slit lamp where you have access to use double filter. What is double filter? It is the one filter for the fluorescent light, which is the blue light, and the other filter is the barrier filter, where it can, eliminate all the other color that coming to the observation part and remain only the green, which is emitted from the fluorescence. So as you see the picture below, you will see the green staining on the black background. So that can enhance what you are seeing on the patient's ocular surface. And then I will use, as you see here, the non-preserved saline as well as the fluorescein. Right now, I'm using fluorescein in all cases. I didn't use rose Bengal because it's very toxic. Also, the lissamine green, I'm not using that much because lissamine green needs time, and sometimes the staining is very weak. But if you use that, that kind of the slit lamp with the double filter, it will bring out very prominent staining. And then if you look at the lower to your right, that is the mammography, which some of the slit lamp, they also integrate the infrared examination light that you can take a look at the Maybelline gland, which is seen here in the upper tarsal part. And then after that, some of the cases, I would like to look at whether they really have the abnormal production, the decreased production of the tears. Then I will send them for Schirmer test and fluorescein clearance test, which gives you the results, not only the production of the tears, but also to see how well the dye, the fluorescein dye, is cleared out of the ocular surface. And I would like to show you here, it's very quick. It's on the, I will put everything on the table, drop it with the normal saline, slash it out, and then ask the patient to look up, touch the fluorescein strip on the lower lid margin, and then ask the patient to blink. This is the filter that I'm adjusting. And looking at that, you can see simultaneously on the screen there, you can observe how the tear film is spreading on the breakup time. And of course, you can record for progression of the patients as well. So I would like to pay more attention, to lead you to more attention about how you can make it reproducible. You just need maybe one drop, slash it out, and put it vertically in the lower lid margin on both sides. The amount of fluorescein that is even enough to spread around all over the ocular surface. And you can observe the tear breakup time right away, because if you put too much fluorescein, the problem is that the tear film is too thick and you won't observe, you will easily miss the staining, and as well the breakup time is hardly observed. You may need longer, 1 or more minutes to clear all the fluid away. And then come to the second part, what is the treatment? When and how? The key assessment in order to adjust your treatment, your dry eyes treatment, is, of course, if you ask me what am I going to follow, the DUS or the ADS? I think the ADS, or the Asia Dry Eye Society guideline, is very easy to follow. So I will use the TFOT, which is the tear film oriented diagnosis, and related to the treatment. That means you need the tear breakup time to see whether it is less than 5 seconds and the pattern of the breakup. You have to classify whether this is an aqueous tear or the short breakup time type or the mixed type. And then when I already have in mind what the patient may have, then I will decide it according to the previous history taking, whether this is severe, how severe it is, according to the patient's own feelings, the frequency of the symptoms. For example, if the patient doesn't feel anything before, just this is the first time that he or she came to your clinic with a very minimal symptoms, that means you may just have to look at the aggravating factors and let the patient to go through by the minimal treatment that you can have. But if the patient is a severe one, the moderate to severe dry eyes, a long history, then you may think about how to maintain the patient with the medication. To see the severity, one of the things is that you have to decide it by looking at the ocular surface staining. Whether it's just, like confluent, you can use either the Oxford grading scale or other system that you can grade to indicate the severity of the damage on the ocular surface. And this is very important. Some of the dry eyes patients, they may come with increasing symptoms and signs because of the associated inflammation. So you have to have your the way to decide whether there is any associated inflammation associated with this time the patient's coming in, so that you can also give some medication to anti the inflammation. Looking at here, this is the 5 types. Actually, I think Dr. Yokoit has just proposed the 6th type, which is the mixed type of the breakup pattern. And you see here, you may be familiar with everything, right? But I would like to point out that for the patients with area break as here, you can see that very minimal tear film moving up. The breakup pattern is just right, breakup time is just right away, and as well as the line break, if you see as a line going upward. And this belongs to the patients in aqueous tear deficiencies group. And if you see there is very minimal staining, but the tear film breakup very rapid, such as the spot break, number 2, and the dimple break, which happen during the tear film movement up, you can notice that this is the poor wettability. That means the patient doesn't have enough mucin layer to protect the ocular surface. And if the patient happen either the fifth type, which is the random break, that is the evaporative dry eyes. That means the patient may have the lipid layers deficiencies, which mainly is associated with the meibomian gland dysfunction. Okay, and this is another diagram which is quite easy for you to use. So classification divided into increased evaporation, aqueous tears, and the decreased wettability. And you see here that this is all the tear film oriented therapy, TFOT, that they suggest to you. What am I using? Actually, this is something like more to the dose type. I will treat my patient as a stepwise treatment. What is stepwise mean? That means if the patient starting with the less severe type, not often a time that the patient may experience. That means they may have experienced dryness, maybe once in a day, not continuously. Doesn't disturb their daily life function. Then I will start with basically the tear supplement. And this is how you can increase your treatment. Increase the secretagogue, anti-inflammation, autologous serum, the punctal occlusion, or even use the surgical treatment. This in the red square is the management for the severe dry eyes. But of course, you have to also consider whether the patient has the MGD or not, because MGD prevalence is quite high, especially in Asian countries. So not only look at the aqueous tear, but you have to also look at the meibomian gland when you examine on the patient's eyes. For this, a limited time, I'm going to focus my talk on the 2 treatment here. You already know about all the tears supplements, right? So I'm going to focus mainly on the secretagogue and the anti-inflammation. Secretagogue means the medicine that can stimulate the secretion of the tears. And listed here on the left-hand side, you can see that is the oral secretagogue. Some of the patients may use it, especially in the Sjogren syndrome, where the rheumatologist prescribe the oral pilocarpine or even the cevimeline for inducing stimulation, not only the tears, but also the saliva and the production of all the glands. But we have the topical secretagogue, which is listed on the right-hand side, especially the P2Y2 agonist, which is the diclofosol. So diclofosol, from the clinical study, they are shown to promote increased aqueous secretion from the non-goblet cell epithelium. Also increase the production of the mucin, both the mucosal-associated mucin and the large gel-forming mucin, such as the secretion MUC5AC from the goblet cells. And it is shown to improve both the symptoms, subjective symptoms of the dry eyes, and as well as the staining score. I would like to just give an example of a case so that you can follow with me. This is a case of a male, 46 years old, diagnosed as the leukemia. And after that, he received the bone marrow transplantation and has been in complete remission up to now. He complained of the burning sensation. That means he has dry eye symptoms 3 years after the bone marrow transplantation and was diagnosed as the GVHD. His current treatment is the artificial tears, the cyclosporin A topical also, but clinical remains the same. And this is the picture of the patient. If you look at just the slit lamp photos, there are minimal information. But when you put the fluoresceins in using the double filter, you can see that there's a lot of the diffuse staining, especially on the cornea, the whole area. And at the conjunctival as well. T-breakup time is short, less than 5 seconds. Schirmer test is very low. And if you look at the first in clearance test, the 3 strip of the Schirmer, which is done 10 minutes apart from each other. And the last copper, the last Schirmer test, we will do it with the nasal stimulation. So every couple of the Schirmer tests show that there are very minimal, less than 2 to 3 millimeters of the strip from the Schirmer strip. And even with the last strip, when you just stimulate to see whether the patient has the reflex tearing or not, no tears at all. And this is the video showing the tear film breakup pattern. What is the type of the breakup pattern here? Very minimal movement of the tear film, right? And you saw there area and line break together with some spot and dimple break. So this is kind of the mixed type of the dry eyes, especially if you have pictures, the history like this. So the patient definitely will have the GVHD, will have the aqueous tear deficiencies, right? But also not only the aqueous, but also the mucin. So I prescribe, I perform the punctal occlusion both on the lower punctum, and I add the 3% diclofenac 6 times a day. And after that, the patient complains of mild irritation after instill the diclofenac, but he felt more waters in the eyes. So this is an example of how you are going to treat this patient. So actually, there are a lot of patients, which I think I will keep it on the questionnaire, but my experience in using diclofenac is that it gives you a good response, especially in the short breakup time, short breakup pattern dry eyes. It can be, you can try it in all types of dry eyes. As in this patient, you can see it's like aqueous tear, GVHD combined with the mucin tear deficiencies. So it also works, so you can try it. Improvement can be observed as soon as 1 month. And most of the patients will tell you that if their response, they will tell that they feel that their eye is moistened, increased water, and the drop seems to stay longer. Some of them even, they can cut down the artificial tears that they are using. There are some adverse effects, but that is mostly tolerable. And this is the way you can reduce the adverse effect of this medication. Some of the patients, you have to tell them that, or even they just come back and tell you that they can feel there are some string of mucin discharge and they have to take it out. So even with that, some of the patients still keep using the diclofenac because they feel the symptoms is better. Well, the second part is the inflammation. In every dry eye patient that come to see you, you have to detect whether there is any inflammation going on under a ocular surface. And this is the best way you can do it practically on your clinic, is that you look at the ocular surface, at the conjunctival redness. Like in this patient, you can see that the eye is totally red, right? And if you put the staining, you can see that the staining is even more. In some of the dry eyes, sometimes they come back to see you. And when you look at the staining, you can see that, oh, there is like, confluent staining, or even sometimes the epithelium is going to slough off or create the epithelial defect on the cornea. So that is because from the inflammation, the MMP9 is releasing, and that can cause the loosening of the epithelial junction. So this is how you can see on the patients with dry eye. And if these patients need anti-inflammatory treatment, which can be the group of steroid, the group of calcineurin inhibitors, the cyclosporin mainly, and the autologous serum. Personally, will know me because it's the non-preserved, we made it in our hospital, non-preserved potent steroid. We made it from the solumetrol, which is the methylprednisolone. It comes in a vial where 2 vial, 500 milligram vial. When you have the powder here and the diluent here, you just discard the diluent and use this powder and dilute it with the normal saline, make it into 1% concentration. And this is very effective, especially in the acute phase of the dry eyes. But you have to be careful in using it. don't give it as a long-term basis, but give it very shortly for about 2 or 4 weeks. And only about 3 times, 4 times a day is enough. You don't have to put like every 1 hour. And the patient will feel better because the inflammation is subside. And then after that, you have to stop it because you don't want the effects of the long-term side effect, like increasing tension or other things. Okay, so if the patient really needs the long-term anti-inflammation, when you start the topical steroid, you have to start together with the topical cyclosporine because it has less side effect. You have 2 types of the cyclosporine A topical in the market. The one which is 0.05% anionic emulsion, and the other one with a higher concentration cationic emulsion. The first in the left hand, it's you have to use it in a BID dosage. That means not once, in the morning and in the evening. Whereas the other preparation, this is only a once daily at bedtime. For my experience in using the 0.1% cyclosporine cationic emulsion for the patients, it is already proof that in severe dry eye patient, it improves both signs and symptoms of the patient. Decreased inflammation by detection of the HLA-DR is less. And this effect can be demonstrated from the first months of the treatment. It's safe, tolerable, and the advantages of the 0.1% cyclosporine is that it's a once daily. It is a once dosage. So the compliance of the patient is more. And I tend to use this concentration, especially in the patient with more severe diseases. It's very effective, which I'm going to show you in the case, the second case, which is the 60-year-old female. She has the secondary Sjogren's syndrome. She has rheumatoid arthritis for years and has been treated with, the tears and the previous concentration of the cyclosporine, but clinical remains the same. This is a picture of the patient, some redness on both eyes. The vision is quite good. The patient also has the conjunctival chalasis, especially in the inferior part of both eyes. And the tear film breakup time is 3 to 4 seconds. And it's a line break, which you can see here. There's a lot of staining on the cornea. That means the patient has quite a lot of the ocular surface damage. Okay. So if you see here, you see that the line break right away in both eyes, right? After I prescribed the 0.1% cyclosporine A on both eyes, 6 months later, when I follow up the patient, the first, the upper panel is the patient before treatment, and the lower panel is 6 months after. And you can see here that the staining on the cornea is less both eyes. The patient seems better in terms of the symptoms, every dry eye symptom. So this is another successful case where you can start the topical 1.1% cyclosporine. So my experience in using this medication is that it's very effective, and that the study has been proven, especially in the in the European country where they have the Santen and all the studies there for moderate to severe dry eyes. It can reduce the signs and especially the fluorescein staining on both the cornea and conjunctival. You can observe the improvement after let the patient come back for follow-up at 1 month. Increased compliance, adverse effects. This medicine is quite a little bit strange to my feeling, because if you put the drop right away, the patient won't feel that stinging. But after 2 or 3 minutes, the patient starts to have the burning sensation. And if you instruct the patient very well what they will expect it after they put the drop on, most of the patient can tolerate this side effect. Well, I also use it not only for dry eye patients, and the patient like severe allergic in children where they have a lot of staining in the vernacular conjunctivitis. That also works very well too. So conclusion, the making diagnosis of dry eyes need both the careful history taking, and you have to perform some essential eye examination, especially use the staining to demonstrate the ocular surface damage on the patient's eye. The important signs to look are the tear breakup time, breakup pattern, the stainings, and sign of inflammation. You have to treat the patient stepwise, starting from artificial tears, and then you increase until the surgical treatment. And of course, it's very important if you have to instruct the patient how they have to live their life. What is the environmental factors that can affect their dry eyes? So that need to be informed to the patient also. And both the dipropofol, 3% dipropofol, can stimulate the aqueous and mucin secretion and works in all types of dry eyes. And the new topical cyclosporin A is very effective, especially in the severe dry eyes with a lot of staining. And the dosage once daily is to increase the compliance. I would like to thanks for your attention.
Thank you very much, Prof. Vilavun, for your very interesting and comprehensive lecture. I'm sure it will invite so many questions from the audience. Is there any questions from the audience? Ada pertanyaan? Do not hesitate to ask questions because we are going to involve you in the discussion as well. Any question from? There is one question, Prof. Vilavun.
Yes.
Hello. Is there any relation between site of incision during phaco and dryness afterward? Maybe correlated due to corneal nerve insertion.
That is very interesting questions. This is the dry eyes after the cataract surgery, right? And well, mostly what we are doing for phaco is 2.75 or even smaller, 2.2 millimeters temporal cornea, right? I don't think there is that significant difference between the size of this very small incision post phaco.
Compared to LASIK.
Okay.
LASIK.
Yeah, that is a very, very good question, especially the refractive surgery, right? We already know that comparing a refractive surgery, LASIK comparing to the relax or smile, because LASIK we are severing the corneal nerve. So definitely it has something to do with increasing dry eyes more in LASIK compared to smile procedures, right? I think the other thing for dryness in the post-refractive surgery is that if you go deeper, like treating higher myopia, then that also increasing the dryness in the patients. Hinge, once we already know that superior hinge may be better than the nasal hinge, but right now, I'm sorry, the superior hinge is worse than the nasal hinge, but most of the new coming paper, they said there is no difference between the position of this hinge of the LASIK. So if you're dealing with the refractive surgery and the patient has pre-existing dry eyes, I will offer to do the smile for the patient instead of doing LASIK.
It's nicer, of course, but it's more expensive.
Yeah.
Anyway, okay, thank you so much for your answer. And there's another one. Nowadays, there are lots of children patients that complain symptoms mimically to dry eye. Is there any correlation between these symptoms to timely consume in front of the gadget, especially now, e-learning? If so, is there any recommendation of how long should a child stare continuously in front of the gadget and then take a rest?
Yeah, that is something that we are, as ophthalmologists, are dealing more and more in the practice, right? Because this is the era of all the gadgets or the tablets and phones.
Cannot stop them.
Yeah, I think that is one part of the computer vision syndrome. Definitely, the patient, actually the Osaka study, which is done on even the adult who is working in front of the video terminal instrument, for example, the computer, they are working in front of the computer. They are showing that more percentage of the patient will experience dry eye. So even with the children play a lot of computer, what I normally suggest their mother is that, I call it a 2020. I don't know, maybe in Indonesia, you can approach them differently, but 20-20-20 rules. That means every 20 minutes, you have to stop using it, look at some objects far away, at least 20 meters away, and then 20-20 rules, and then for about 20 seconds. So I think that is one thing that related to the how they are using their eyes. The other thing that I found more dry eyes in the children is in the children who they have the allergy and they have to take the oral anticholinergic or antihistamine. And that medicine in a long term can cause dry eyes. So if it's a children coming to see you with dry eyes, so I will pay more attention on this to causative cause.
Do you give artificial teardrops for children?
Yes,
of course. Is not, it is not. Usually, dry eyes is in old age, but nowadays in children, it is not the time actually to use artificial teardrops. So you do to children.
But I think the most important thing is you have to find the causative factors.
And there is also any other question? Yeah, there is a. How long do we use artificial teardrops before considering diclofenac or cyclosporine?
I'm sorry, can you repeat it
again? How long do we use artificial teardrops before considering cyclosporine or diclofenac?
Well, actually, I approach a patient by looking at the severity, as I showed you. If the patient has, already severe symptoms with, you see some of the ocular surface damage, then I tend to use it at the same time, not only the artificial tears, but also I will give them, anti-inflammation as well, especially in the group of the patient coming for refractive surgery, when you have to calm down all the environment as fast as possible in order to proceed them to do the surgery. Then if they have dry eyes, they have short breakup time, they have staining, then I will start both the tears together with the topical cyclosporine.
Next question, how long do you give cyclosporine 1% for the dry eye patient? And it can be combined with other topical drugs. Can it be combined with topical drugs? What type of drugs that you choose?
Yes, I think I have partially answered that question. If it's a chronic dry eyes, then the patient may need a long-term topical cyclosporine. Well, maybe 1, 2, 3 years in a chronic case, for example, like the Jochen syndrome, when you cannot, deal with other things, they already damaged the lacrimal gland. So I give them longer, and of course. In the severe case, like the Jochen syndrome, I would give the topical tears together with the topical cyclosporine and follow up them. Sometime in this group of patients, they may come back with exacerbation of the symptoms. That means they have inflammation aggravation some of the time. Then it's the time that you may add, some topical steroid, especially the potent steroid, for a short period of time. So that can control the symptoms for the patient.
You mentioned that if there is symptoms of dry eye, but the eye is okay, so ocular surface is very good, so you call it preclinical, you mentioned this a clinical type, okay? So yes. How do you indicate the frequency of instillations of the teardrops?
You mean?
How many times a day? How do you decide how many times a day the instillation?
You mean in this?
In preclinical dry eyes,
right? It depends on it depends on how much how many drops that they put in, and then they feel better. But mostly these patients, for example, we found a lot after the surgery, right? Post-cataract dry eyes. The patient, a lot of complaint, but you found nothing on the patient. So these also make you have to consider about the neuropathic pain. This is a type of the dry eyes, which I think is quite difficult to treat because you don't have, we don't have the available drug, although it's coming in the future commercially. But right now we don't have the specific treatment for treating the neuropathic. So I never used the the medicine that the neuro use for the post-herpetic neuralgia. But sometimes if the patient is that severe, I may make the autologous serum and prescribe it to see whether that can help the patients. Very difficult. What about you? How do you treat this kind of like post-cataract dry eyes?
Nowadays, there are many middle age, not old patients, young patients, those working in the in the office nowadays. All these office buildings, all with high air condition, and they are staring all the time on the computer. So most of them have dry eye, although not very severe. Although it's just preclinical, there's no damage to the ocular surface. I used to say, I always give sometimes artificial teardrop, of course, without any other, just a simple one, and then ask them to put and see how long this drop stay comfortable. So how long this one drop makes you comfortable. If it stay only for 1 hour, it means you have to put it every 1 hour. Appropriate, I mean, more or less. That's the way I used to give, patients. Just to say how many times, because sometimes, some people, they have to put it very frequent, some are not. So it depends on the teardrop itself. Long time ago, we used to give, for example, we are advised to give 1 or 2 types of artificial teardrops. And then let the patient choose. I mean, try and choose which one he prefers, because the aim of the treatment is to give comfort to the patient, right? There is no damage to the ocular surface, so we don't have to give any other, If there's inflammation, of course, we have to give anti-inflammation, but it's not very necessary, right?
Yeah, and also the patient responds to different artificial tears differently. Sometimes they like this one, they don't like this one. But right now, I think we are, especially in our country, we have a lot of choice to choose, right? Even the thicker or the thinner artificial tears, some with the hyaluronic, different concentrations. So you just have to try with the patient whether which one they like it.
The same way, we give them. There is another question. Do you think that the aqueous deficiency ADS guideline may also suitable for monitoring the treatment?
Which one? Which guideline? Guideline for the diagnosis, or you mean the TFOT, or I can't really get
Asian Dry Eye Society guideline also suitable for monitoring the treatment.
You mean monitoring the treatment? Well, if you look at the, I don't know whether I am answering the right questions. Yeah, actually, if you look at the TFOT, tear film oriented therapy, I think they have provided quite a good number of the choice of the treatment in each. But I would say that we have some of the tiers, we have more than them, but some of the treatment in the TFOT guideline is quite interesting. For example, the rebamipine, we don't have it in Thailand, and as well as in our Southeast Asia region. So I think that medicine is also maybe very interesting to use in some specific type of the patients. Well, I don't have the right answer to that question. What about you?
I do not rely on the AIDS guidelines.
Mm-hmm.
I do not. I mean, I myself, just depends on the patient. It is very individual. Sometimes even the the fluorescein pattern. Is it consistent in every? I mean, for example, in aqueous deficiency, is it consistent? The picture is just like that, the pattern, or they may also different pattern.
Yeah.
You know, for example, a patient with aqueous deficiency, and do you think the pattern will be the same from patient to patient, or it has individual variation?
For the aqueous deficiencies, I think we have varieties of treatments, especially address on the supplement of the tears as well as suppress the inflammation. So I think that is the key point, that you have to treat and follow the patients well. But another interesting aspect is that you have topical diclofenac, which it is recommended also in the short breakup type. So right now, previously I didn't try to diagnose this type of dry eyes, but I'm seeing the pattern of the breakup time, and if the patient has a short breakup pattern with the symptoms of the dry eyes, then this is the medication. The diclofenac is something which I just use it in most of the cases, and most of them respond quite good. So I think this is another option that you can, is another indication you can have.
Another question: do you have any experience with systemic secretagogue?
I see. This is quite interesting question as well. I have one patient who is the Signy-Jochen syndrome. She has the rheumatoid arthritis, but she has been treated from the immunologist elsewhere. The immunologist prescribed oral pilocarpine, which is the Salagen, and the brand is Salagen. And I look at the patient's eye and ask them whether if she stopped it, what would she feel? And she said that when she used the Salagen, it makes her eye more moistened. I think we are not the one who prescribe the oral or the systemic secretagogue, but the immunologist will prescribe it. But you have to be aware of the other side effect. For example, they have a lot of saliva. So, but this patient, he preferred to use the oral Salagen because she said she's feeling better with the the oral secretagogue.
There is also another medication called mucolytic, oral mucolytic. Is it works? It works for sometimes it is, it is it is written in books. Sometimes you have to give that also try at least. Have you tried it?
Well, in some of the patients, I try it. Mucolytic, for example, the topical acetylcysteine. Is that the one you mentioned? Yeah. You have it in Indonesia? We have it in Thailand. So in that particular cases, I would use it. For example, in cases where they have like the FK, filamentous keratitis, or they have like abnormal increased production of the mucin. So I would use that medicine. But for the ordinary dry eyes patient, I don't use it.
Mucolytic, and then so any other questions from the audience, from the participants, not audience? Where are they? Where are participants? Yeah. Okay. From the hello, from
Professor Vilavun, there's a question in the chat box that probably being missed. So do you have any experience on dry eye patient with moderate to severe conjunctival inflammation, staining and hyperemia without corneal involvement, no SPK? Would you treat this patient with anti-inflammatories such as steroid or cyclosporine?
I'm thinking about my actual patient. Normally, if it's the more severe dry eyes, you would see the staining on the cornea. So if it's the staining is on the conjunctival alone, I don't think it's that that frequent. I will see the staining both on the cornea and the conjunctival. So with that, then you have to consider start the treatment, not only the tears, but start using the anti-inflammation as well as the the topical secretagogue.
Do you
Thank you.
think cyclosporin is it will increase the number of goblet cells?
Cyclosporin, yes. The paper that already published, they said that after using the topical cyclosporin, the goblet cell density increased. So that is proven in the paper coming out. But it's I think it's the previous concentration, 0.05% cyclosporin.
If the conjunctiva is good, at least. If the conjunctiva is not healthy, do you think it will?
You have to try. Yeah, for example, patients with
yes, if it is good, we have a good armamentarium for treating Stevens-Johnson syndrome.
Yeah, that is the disease that the diseases on the conjunctiva also. So that is quite challenging cases when you think about the abnormal conjunctiva, where very less goblet cells. Yeah, the squamous metaplasia.
How can we, we grow or increase the number of goblet cells?
That is. I don't think that can work as well, very well as the one with the normal conjunctiva.
Another question. There is another one question. How about dry eye in Sjogren's syndrome? In Sjogren's syndrome, if the systemic inflammation is controlled, would increasing the systemic immunosuppressive treatment?
Yes.
SMPX or CellCept?
So that is.
We have to increase the immunosuppressive treatment if the condition is controlled.
Yes. Yeah. You're asking about the systemic treatment, right? In the real life, when you have the patient coming to you with the Sjogren's syndrome suspected, then you send this patient to the internal medicine, right? For them to the diagnosis. And most of the time, the internal medicine will send the patients back, and then they said, well, he has dry eyes, but the level or the severity of the systemic autoimmune is not that severe, so they're not starting with that, systemic immunosuppression. So it leaves all the work to you as an ophthalmologist. Most of the case will be like that. Most of my cases, but we cannot start. I mean, I don't think we should start the systemic immunosuppressive treatment by ourselves. That is quite dangerous. If you're not a uveitic or the inflammatory, the specialist, then you have to be out of this.
There are so many cases referred to us with Sjogren's syndrome from the autoimmune disease department, and then but I do not see any signs of damage or dry eye even in those patients. So what do you do?
I think
they ask, what about the sometimes the treatment is what is the treatment they give usually very strong oral medications, and they have so many side effects. So how then? What is this Sjogren's syndrome? Sometimes the eyes is just quiet. Shimmer test is good. Sometimes they are bad, very low shimmer test, but sometimes they are no problem. I mean,
yes.
See them or you don't see?
Yes, I also see a lot of patients because sometimes they, for example, the rheumatoid patient or the SLE patient, when they start the patient with for example, the hydroxychloroquine, they will refer the patients to us. Right, to see whether there is any side effect from that hydroxychloroquine. And I look at the patient's eye, they rarely have dry eyes. So it's vice versa. Sometimes you saw, aggressive systemic autoimmune diseases, but it's show very minimal dry eyes. But in another word, you can see a primary Sjogren's syndrome where you have a lot of, dry eyes going around, but the systemic is not that severe. So I think it's, maybe because of the differential attacking of the autoimmune on different glands in the body, I think.
So just observe, follow. There is maybe, this is the last question. Do you have any experience in treating filamentary keratitis with topical cyclosporine?
That is another very interesting question, because sometimes we
Alright.
found a lot. We found a lot of filamentous keratitis. Filamentous keratitis can be after many causes. Not only the dry eyes patient, but also some patients like blepharospasm, patients with stroke, patients who are paralyzed and on bedridden. Sometimes they have a lot of FK, and it's very difficult to treat. So it depends on the different type, different settings of how the FK was manifest. Mostly when I saw, for example, for dry eyes patient and the FK, recurrent FK, I will treat them, I will put them on the topical cyclosporine. But for some other, other causes, for example, the blepharospasm, you have to attack the mechanism that can induce the filamentous K. So don't only give the topical cyclosporine. You have to look at other causes as well.
There's so many causes. You have to do the videmang first, of course, right? To remove the filament. You do the videmang to remove the filaments, and then what do you give after that?
You mean the filament?
The filament.
FK.
Sometimes there are so many, even without. There's one case with a stroke. Maybe it is maybe the trigeminal nerve, maybe the cornea is not so healthy. So the filament is frequently, appearing. So every time I have to remove the filament and then put artificial teardrops and bandage contact lens. Sometimes it's very lens to prevent reappearing of the filaments.
And I think for the FK patient, you can see that their eye is very red. I think because of the mechanical of that filaments, they induce a lot of papillary reaction on the tarsal conjunctiva. So that if that kind of inflammation is inside the eye, then you definitely need topical corticosteroid short therapy in order to suppress that inflammation as well.
Okay, udah habis waktunya. So, because of time, we would like to have more discussion with you actually, but time is limited, so we have to end this session, this webinar. And this is my so to conclude, that in any case of dry eye, we have to first history taking must be very good, and then complete examinations of the ocular surface. Not everyone, we have mammography. Not everyone can see mammography, in our clinic. Some have, and of course, but sometimes you don't have. Not everyone can do all these tests. What do you say then?
Yeah, I don't think there are.
No, you have to do the test, your fluorescein test, shimmer, and so on. But sometimes it is not available in the clinic, especially in rural areas. So what do you do then? If there is no damage to the ocular surface, just give any artificial teardrops.
You are asking me, right?
Yes.
Sorry, I thought that was the conclusion.
Okay. Yeah, not yet conclusion, not yet.
Okay. I think what you really need is a good history taking and look at the patients. I think fluorescein is very crucial. Everywhere you can get the fluorescein, right? Even the commercially available, or you can make it by your own. I think that is very crucial to have. And do a good staining to see whether there is associated ocular surface damage or not. And Schirmer test to see. But other than that, as you mentioned, the mammography, if you don't have the mammography, you can also take a look at the lid margin, expressed and observe how well the mebum is secreted, what is the quality and the quantity, and that can give you an idea. So I think this is basically what you really need to diagnose cases with dry eyes. You don't need that sophisticated or fancy investigation for your daily practice.
Okay, thank you so much. as conclusion, in any case of dry eye, it is sometimes not that easy as it is. Sometimes we have to look for the underlying cause, and if possible, we have to decide whether it is aqueous deficiency or whether it is mucin deficiency or lipid deficiency. And it is not only that, we have also to know the nervous system that is, involving in the system, and also the what do we call it, the microocular this environment, ocular surface environment, this microenvironment that is also affecting, play a role in the occurrence of dry eye. But the aim of the treatment is, of course, to give comfort to the patient. If possible, if we can find the etiology, so maybe we can stop the dry eye, the disease, or the patient will be happy because they don't have to put the drops every 1 hour, every 2 hours, every day for the whole of her life. Thank you very much, Prof. Vilavun.
Perfect.
See you again. Hopefully we can see you again Sunday.
Thank you for
also better than. Okay.
hope the best to all of you. All are very interesting questions. Thank you for your moderation.
Yeah, actually there are so many questions, but sometimes.
Yes.
Sometimes I get lost. All right then. Thank you so much. Let me give the mic to Pak Hadi. And maybe Prof. Ratna would like to say something.
Yep. Thank you very much, Dr. Fatma, for leading our session and discussion, a great discussion. Thank you very much, Professor Vilavun. Before we end this session, we are having dear Professor Ratna Sitempul as the head of INOS. Would you like to give some speech, please, Professor Ratna?
Assalamualaikum warahmatullahi wabarakatuh. First, I would like to say thank you very much for Professor Vilavun and also Dr. Fatma, who already moderate us and guide us about how we be able to treat our patient better due to dry eye. I think what Professor Vilavun already said is very clear to us. So it is our duty now to try or to be able to follow, whether it is TFOS or TFORT or others, but we need to follow one of them and then treat our patient in a better way. So thank you very much for your very, very interesting lecture. And also thank you very much for Dr. Fatma, who already guide us and also giving answering most of the question. To Santen and also Meiji, I would like to say thank you very much also for your support for ophthalmologists in Indonesia. Dan untuk teman-teman sekalian, tentu saja beberapa kali kita sudah menyelenggarakan webinar seperti ini dan topiknya jelas, yaitu tentang dry eye. Namun demikian, banyak segi dari dry eye ini yang dapat kita perhatikan. Apapun guideline yang teman-teman ingin gunakan, gunakanlah dengan sebaik-baiknya, karena pada intinya kedua hal ini ada perbedaan, ada persamaan. Apapun senjata yang teman-teman pakai, asal mengikutinya dengan baik, saya rasa kedua guideline ini akan sangat bermanfaat bagi teman-teman. Itu yang pertama. Jadi peganglah guideline-nya. Yang kedua, dalam menangani dry eye, banyak sekali segi atau banyak sekali hal-hal yang harus kita perhatikan. History taking, of course. Tetapi kalau teman-teman bisa mengusahakan, kerjakanlah pemeriksaan menggunakan fluoresin. Memang pertama kali kita menggunakannya untuk mencoba melihat break up time, jenis apakah yang dimiliki oleh pasien kita. Sekali, dua kali kita, aduh ini apa ya, lupa lagi, atau wah ini yang mana ya, bolak-balik kita harus melihat ke guideline yang Profesor Jokowi itu kerjakan. Tapi kalau itu dikerjakan, menurut pendapat saya akan sangat membantu penanganan kita kepada pasien. Karena dari situ kita bisa membedakan kira-kira kelayanannya itu tipe aqueous defisiency, tipe lipidkah, atau tipe musin. Dengan mengetahui ketiga hal tersebut, kita kemudian bisa memberikan treatment yang sesuai, gitu ya. Kalau dia ada inflamasi, ya kita tambahkan antiinflamasi dan sebagainya. Tetapi ini merupakan hal-hal yang menurut saya sederhana dan bisa diikuti. Sehingga mestinya teman-teman bisa menangani pasien-pasien kita dengan jauh lebih baik dari sebelum kita memberikan pengetahuan seperti ini. Saya juga mengucapkan terima kasih atas kesediaan teman-teman mendengarkan sampai habis. Kelihatannya semuanya sangat tertarik dan mudah-mudahan ini sangat bermanfaat buat kita semua. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Ratna, for a wonderful speech. Again, I would like to say thank you for Professor Vilavun. It was a great session, a great webinar. Hopefully, we can apply your knowledge here in Indonesia. Thank you, Dr. Fatma, for moderating. So this is the end of our webinar. Allow me to remind all the participants, all the attendees, to fill in the form already in the chat form. In the chat box, there's a form that you can fill in for the certificate. And also, even for the participant in the YouTube streaming, there's a link there. Just click the link and then fill in for your certificate administration. Again, thank you all. Have a wonderful weekend. Bye-bye.
Bye. See you again.
Bye-bye.
Bye-bye.